Up next, Anthony DeMaria and Dr. Steve Keteyian, director of the Preventive Cardiology Program at the Henry Ford Hospital in Detroit, Michigan, discussed the relationship between volume of exercise and clinical outcomes in patients with heart failure.
Dr. Keteyian, perhaps you could give us the background for this study in heart failure patients.
Thank you very much for the opportunity. Many may know the testing of exercise training in patients with systolic dysfunction has undergone an enormous amount of study over the past 20 years, and must have been about 2 years or so ago we completed a trial, the HF Action trial, which was a large randomized trial in which patients with systolic heart failure were randomized to exercise training, which involves supervised cardiac rehabilitation type training and then some home-based training versus no exercise control, and then followed for several years in each of their arms. And what we've done with this analysis, or this paper addresses, as a secondary analysis, it addresses really the important question, specifically what's the relationship between the amount of exercise that patients did in the trial and the impact or its relationship to our primary outcomes of all-cause mortality and hospitalization, or a heart failure-specific endpoint of cardiovascular mortality or heart failure hospitalization, and then a final outcome relationship between exercise volume, how much they did, and change in fitness or exercise capacity.
So I'm trying to imagine this because many of the congestive heart failure patients, particularly those with reduced ejection fraction that I take care of, really are considerably limited even in activities of daily living. So I'm wondering, tell us a little bit about the patients that you managed to enroll in this, and what exactly did the exercise training regimen consist of?
We tried to make the eligibility and the enrollment criteria as broad and generalizable as we could to address that large patient population that we know exists. So we were specifically looking for patients with an ejection fraction less than 35%, NYHA class 2 or 3, on stable medications for at least 6 weeks, which for us we were most concerned about beta-adrenergic blockade therapy and afterload reduction by ACE or ARB. And that was for at least 6 weeks on their therapy. And then the type of training we would engage them in, patients after some preliminary testing at baseline, were randomized to either 36 sessions of supervised, typical cardiac rehabilitation type exercise in a supervised clinic setting. And that exercise was roughly 3 times per week for 60 minutes per session. Of that 60 minutes, we wanted at least 30 to be walking or biking in more of an aerobic training fashion. And then upon completion of their 36 visits, or partway through their 36 visits, we started to introduce some home-based exercise, and then fully transitioned after 36 visits to all home-based exercise for 4 or 5 days per week for about 30 or 40 minutes of aerobic training per session, versus going to a control group that received some educational advice about exercise initially in terms of standard care, but then were not specifically guided with exercise after that.
Was this kind of a walk, run, jog type conditioning, or did it involve some isometrics or weight? What kind of exercise?
In terms of modalities, it was all stationary biking or treadmill walking. There was no resistance training or weight training, no isometric training whatsoever. And it was what we would think of as more the classic aerobic type training, as I said, walking. The methods that we used, we tried to train them at a percentage of heart rate reserve, which in this case we try to train them roughly between 60 and 70% of heart rate reserve, maybe 75% of heart rate reserve, but in that general area. It's at an intensity that in the single-site trials and other trials had shown to be a sufficient stimulus to induce an improvement in exercise capacity and some other physiologic parameters. And then that's what we did, 3 times per week, and then eventually they did on their own at home.
So I remember when I was about to read this paper, I looked at it and it said, it seems to me fairly apparent that the more someone is able to train, the lesser the severity of their illness, and so I would have anticipated that there would be a lesser number of events. Is that what you found?
So clearly, the more somebody did, there were fewer events. I should introduce a new term for some of the people listening to kind of gather together the full impact of their training. We tried to sum up, so to speak, not only how long they went each week, but how hard they went. And the unit we used for that, it's called exercise volume, and the unit we used for that was MET hours per week. So if somebody walked at a 2 MET exercise intensity and they did that for 2 hours per week, their weekly exercise volume would be 4 MET hours per week. And we showed that people who trained roughly between 3 to 5, or let's say 3 to 7 MET hours per week, compared to people who did not train at those levels or trained at lesser amounts, those people who trained at the 3 to 5, 5 to 7 MET hour per week level had fewer endpoints, both our primary and secondary endpoint.
What happened to the people who could train at a higher exercise volume or a lower exercise volume than the 3 to 7 MET hour per week that you mentioned?
So if we split out our two clinical endpoints, the first one being all-cause mortality and all-cause hospitalization, we noticed that people training below 3 MET hours per week, their reduction in, or their hazard ratios or their reductions in risk were much less, probably in the area of maybe an 8 to 10% reduction or less, versus the reductions in adjusted risk for people who trained at higher levels, 3 to 7 MET hours per week. You know, they experienced reductions in risk that approached 25 to 30%. Now, interestingly, and I think this is one of the questions you were asking, is that people who trained above 7 MET hours per week, we noticed that the adjusted risk started to drop. It wasn't quite as robust, let's say at 30%. One might suggest, well, it was exercise harmful in this case, and probably not. I think we're just seeing that the exercise component had less of an effect. When you've adjusted for all the other variables as well, these patients were probably a little bit healthier out there that could do 7 MET hours per week or more. Therefore, exercise had a little less of an effect in improving their risk. So it was almost a J-point curve that they were experiencing, or a J-shaped curve. And that was for the primary outcome. For the secondary outcome, we saw, again, a J-shaped curve, nice decreases in risk as people progressed from our index point all the way through 3 to 7 MET hours per week. In fact, at 3 to 7 MET hours per week, we're looking at reductions in risk now that exceeded 50%. But then when we got above 70%, the adjusted risk fell off a little bit, wasn't quite as pronounced. And again, we think, or at least one could make a strong argument, that these were healthier people with a baseline healthier substrate, so to speak, and therefore exercise had less of a beneficial effect on them.
I could understand how the people who are in really good shape and could exercise at high volumes might have a lesser percent reduction in events, but my assumption is if you looked at absolute events, they still had a very small number, small relative to, say, the patients who could exercise at less than 3.
And there you might look at an unadjusted risk rather than an adjusted risk profile. Is that what you'd be kind of tracking at?
You could use that approach, yeah.
If we do, then the unadjusted risk profile, in fact, we have 2 really good figures in the paper that look at this. The unadjusted profile no longer shows a, so to speak, uptick in lessening risk. Those people's risk tends to plateau out at the 7 MET hour per week level, not necessarily being higher or lower than the people at, let's say, 5 to 7 MET hours per week. So their unadjusted risk has actually plateaued out there.
Simplistically, what's your message? Your message is not that if people can exercise at a high volume that they shouldn't do it because they won't benefit, I don't think.
No, that's clearly not the message. I would flip it around and say for sure the patients that can exercise with systolic heart failure on stable therapy, and we would like to get those patients up to at least 3 to 7 MET hours per week. And for those patients who can and are able to and interested in train at higher levels, there still is some effect from exercise, but not just quite as dramatic as we've seen in terms of after adjusting for their baseline health, so to speak, as we saw in those patients that were a little less healthy upon enrollment in the trial.
But essentially, based upon this study, you would favor that everybody who can exercise should exercise to the limit of their exercise capability.
Yes. One could also make the argument that if we look at other factors besides just clinical outcomes, that other factors, be it either fitness or quality of life or self-efficacy and other things we might be interested in, even some physiologic parameters, one would make the argument there that those people should probably be exercising for some benefit in those areas as well, but further exploration is probably needed in those domains too.
I congratulate you. As I say, depending upon the individual patient, many of the patients I see with heart failure and systolic dysfunction are limited in exertional capacity, and I think your data have pretty clearly shown that you can get benefit at any level of training, but that it's particularly large in those individuals who are capable of performing in the mid-range of exercise capacity. And so I guess the message to all of us is to try to get our heart failure patients out on a treadmill or bicycle.
I appreciate your commentary, and I will say that's where we would like to take it. Unlike many of us were trained 20 or 30 years ago, and some still practice, that engaging these patients in regular, modest exercise in addition to their standard therapy, on top of their standard therapy, is helpful from a clinical perspective.
Great. Well, thanks very much for sharing this with us.
Thanks so much for having me.